warm welcome. Welcome everyone to this afternoon session. We're going to be talking about delirium and about respiratory systems and the symptoms in the palliative care setting. Both very important symptoms that we see uh, in palliative care, in end of life care, and also while we're looking after people who are terminally ill. Two very important groups of symptoms. Um, Let me get the slides up on screen for you. So I hope that's visible to everyone. Um, okay, so I'm going to start with very fundamentally, what is the definition of health? I think these couple of points are so important that we can't really emphasize it too many times. So let's look at it. What actually is health and what is our work as healthcare professionals all about? From the WHO's constitution, we know that health is a state of complete physical, mental, and social well being, and not merely the absence of disease or infirmity. So, this is a broad ranging definition which tells us very clearly that our focus of care should not just be on physical well being, but we should look at psychosocial and other aspects too to promote holistic care. And when it comes to palliative care, what does the WHO tell us? The WHO tells us that palliative care is an approach that improves the quality of life for patients and their families. Facing problems associated with life threatening illness through the prevention and relief of suffering by means of early identification, impeccable assessment, and treatment of pain and other problems, physical, psychosocial, and spiritual. So, two very important clauses I'd like to draw your attention back to again. So, it's quality of life for patients and their families. So, this clearly tells us that our remit of care also includes family members. And it's about treatment of pain and other problems, physical, psychosocial, and spiritual. So it's not just looking after their physical well being, but clearly we have to make sure that we are looking after their mental health and also promoting spiritual well being in whatever way we can. I'm sure most of you recognize this person. This is Dame Cicely Saunders, who's widely accepted as the founder of the modern hospice care movement. So she was a nurse who worked in the UK, recognized the suffering of soldiers who were dying after the Second World War. And the NHS was growing in stature and was providing such good quality healthcare. But she realized that it's not important just to provide healthcare for those who are quote unquote healthy and just having reversible illnesses, but it's very important that people also get an opportunity to die well and that they die comfortably. And she gave us these four pillars of domains of care for palliative care. That's the physical, the psychological, the social, and the spiritual. So for every patient, sorry, there's an interruption. Thank you. So to sort of divide up the symptoms and to see where we should focus our care, it's useful to have these four domains to make important checklists. Like in the physical domain, we have to deal with pain, we have to deal with nausea, and we have to deal with itch. And then psychologically, there's this problem. Socially, there are these issues, and spiritually, there's this to be taken care of. But what we should also remember always is that these four domains are very dynamic, and they are also very closely interrelated with one another. And what does that mean? When we treat some physical problem, we can make psychological problem better. When there's very bad physical pain and you treat it and you lessen that pain, you can cause psychological well-being. And on the reverse also is true. When someone is telling you he has a pain score of 10, it's just not getting better, you can't just keep increasing the analgesics over and over about a certain amount. There's a lot of scope to increase it. But at some point, you have to stop and think what else is contributing to this pain? It's not just the physical problem. There's also something going on internally. Maybe it's spiritual pain, there's some loss, maybe there are some psychological stresses that need to be dealt with. So it's very important that we keep looking after these four domains throughout our care. And it's again not just with pain, although I've used the example of pain a couple of times, it's with other symptoms as well. And again, in palliative care, what's very important is that we work together as a multidisciplinary team. At the center of care is the patient and family. And then all of us have a very important role in working together to ensure that we provide holistic care for patients and their families. So let's come now to delirium. What is delirium? To put it very simply, delirium is confusion. If somebody is confused, we say that they are delirious. Looking at the definition, delirium is a serious change in mental abilities resulting in confused or disordered thinking. It usually comes on within hours or days. That's the important thing. It comes quickly. And sometimes symptoms of delirium may come and go. Someone may be confused, but a few hours later, maybe they've slept, maybe some family has visited them, they've gone. Then after a while, they're starting to look better. And then it comes again. This can happen quite often with delirium. And another classical thing about delirium is that the symptoms are often worse late evening or at night. This is called sundowning, sundowner symptom. Because as the sun goes down, these symptoms get worse. And there have even been some theories postulated about this, that it's something to do with the variation in the diurnal light and things like that. But we don't know for sure. But delirium can get worse at night. In the palliative care setting, we see a lot of delirium. It's one of the most frequent complications. More than 80% of our people are delirious, have some amount of delirium at the end of life. Why is it so? When you think about it, patients in palliative care, they're not eating well, they're mostly not drinking well, they're more prone to dehydration, they're more prone to electrolyte disturbances, they're also under huge emotional pressure, emotional stress, okay, and they're on a huge variety of medications. A lot of our palliative care medications, starting with opioids and others, they can have delirium as a side effect. So there are lots of reasons why we can see this symptom in our patients. Are we okay so far? Anybody has any doubts? Please feel free. You can raise the hand icon. You can unmute yourself and ask questions, or you can even type it into the chat box and we'll keep an eye on things as we go along. There will be time at the end also for everybody to ask their questions. So, delirium starts suddenly over hours or days. Okay, and it's like an alarm bell. It's a sign that this person is physically unwell. There's something happening here, and it's for us to see whether whatever is causing this delirium is reversible or not. So, when they feel confused, how do we notice it clinically? Impairment of attention. They're not paying attention to what we say. Do you want to have some food? Do you want to have a drink of water? They're not really focusing. They're looking somewhere. Okay. They feel confused. They develop problems with their memory. And it seems like as if they're suddenly behaving very strangely. They say or do things that are out of character. It may become even very obvious. They're disoriented to time, place, or person. When you go in the morning to check them, you may be providing for them on a daily basis, care for them on a daily basis, but suddenly they'll be like, who's this person? Why are they coming close to me? Ask them, where are you? And then they'll be confused. Where am I? They're not sure where they are, what time of the day it is, or recognize the people around them. It could be a memory deficit. In that, if you ask them, like what happened yesterday, or what did you have for breakfast today, they find it difficult to recall. They find it difficult to concentrate. Trying to have a conversation with them, telling them, did you open your bowels? Did you sleep well last night? They're not focusing, they're not replying to you. Language deficit. They'll be searching for words. Suddenly that old person, let's say in bed number 7, very cooperative, very nice patient, just came in for some treatment of UTI. What is happening? Suddenly he's becoming difficult to control. He's pushing off the food. He doesn't want to eat. What's happening? So that's slipping into delirium. It could also become, sorry, in the previous slide, it could also become a slowness. Okay? His movements and activities, it could be that they are more withdrawn, lying in bed, not responding easily, pushing something away, pulling, turning towards the wall, not replying to whatever we ask them. They could have frank hallucinations or delusions. I saw somebody looking through the window, they'll say. There'll be nobody there, nobody's face there at the window. They'll see something totally strange. Or sometimes you'll see them in bed talking, having a conversation. Who are you talking to? My daughter's come to visit me. I have to see her off. It could also be in the form of an emotional change. They could be more irritable, angry, or they could be depressed, or they could be rapid changes in emotion. Suddenly they'll be shouting at you, pinching, pushing away, or they may burst into tears and they'll have some tears flowing down their face. And what are the other things we notice? This is very important. Changes in the sleep cycle. Very difficult to get them to sleep at night and wake up at the usual time in the morning. They may be awake all night, muttering and disturbing the others around them. And then what will happen? During the daytime, they'll fall asleep late and then they'll be sleeping very comfortably for the rest of the afternoon and for the rest of the evening. So roughly we say there are three kinds of delirium. Broadly, we say there are three kinds of delirium. Hyperactive delirium, hypoactive delirium, and a person with a mixed picture. As the name suggests, hyperactive delirium is when the patient is more agitated. They're restless, he's anxious, they're suddenly getting out of bed, they're trying to walk out of the ward. And we stop them and ask them, what do you want? Where are you going? I have to catch a bus. I have to go and meet someone. And hypoactive delirium is the opposite. The person is more withdrawn, they're drowsy. Somebody who will wake up cheerfully in the morning and eat whatever is given to them, they keep pushing their food. And if you try to talk to them, do you want to drink something instead? They're not responding. Okay, it may even be more subtle than that. Sometimes it's not very obvious at all. But when you are providing care to someone on a daily basis, usually it's the nursing staff, and we rely on you to pick up those changes because you can notice it fast and notice it well. There's something not right about this person. He was different for the last few days, but today there's something different about him. It's not his usual picture. And that's enough. That's a very good clue to know that someone is getting delirious. They're confused. They're not what they were. And a person with a mixed delirium has symptoms of both. There's both hyperactivity in their behavior and there's hypoactivity. They could be completely withdrawn at times, or they could be jumping out of bed and disturbing everybody in the ward. Now, whatever the picture is, whether it is hyper, whether it is hypo, remember delirium can be a medical emergency at times because we have to know what is causing the delirium. Okay? Depending on what that is, sometimes you may need to move quickly because if it's a reversible cause, then you can reverse it, you can do something to fix it, and it helps the patient and their families in a very big way. So, what are the problems of delirium? When someone is delirious, there's an increased risk of falls. Okay, when they're getting out of bed, trying to walk around, their stability also is not good at that point, and increased risk of falls. And a fall is the last thing we want in somebody who's elderly, as you know, because once they fall, they hurt themselves. It's very often the beginning of the end. And then somebody is delirious, there's more risk of pressure sores. It's difficult to turn them around, it's difficult to position them, it's difficult to give care. Delirium in a hospitalized patient also results in longer hospital stays. We are trying to get them quickly stabilized so we can get them back home. We're trying to get them back to an atmosphere where they're comfortable in, but delirium can prolong a hospital stay. It can also cause increased mortality. Okay, somebody is refusing their medications, not cooperating, then causes increased mortality. And very importantly, something we don't realize often is that delirium is extremely distressing for the family members. It's possibly also something which is very distressing for the person themselves, though they're not able to express it. When people see their loved ones not behaving the way they do, and when they are acting like this, it's a very emotionally distressing state because they feel, it's a complete loss of dignity for them. It's like this person who was in a place of respect, they feel that they're making like a fool of themselves in front of everyone. They'll often be like, why is, is my parent, is this person becoming mad? What is happening? Do something, please. Okay? Because again, when we know, for us, we accept it and we don't judge them. People, when they're delirious, they can do all sorts of things. Suddenly, they'll start being on incontinent, they can wet themselves, they'll say some very foul language, some distressing things, or something which totally doesn't make sense. I saw this in the window, I saw a horse, I saw something go by. And, people think, why is this happening? This person is not like this. My father is such a respectable person. Why is he talking like this? Do something. Please do something. What's happening to him? And in the elderly, we should also remember symptoms of delirium can be confused often with symptoms of dementia. But there are some striking differences between dementia and delirium, and we'll come to that. So, delirium, as I said, can happen suddenly, can start over a few hours. Somebody who's okay in the morning, suddenly towards afternoon, is very confused in doing things. But dementia, it's a very, very gradual onset. As we know, it's a slow loss of memory. Usually, it's memory that fails. They forget names, they forget faces, they forget words. And then things slowly get worse over a period of, we're talking months or years. Delirium may fluctuate during the day. And if there's a diurnal variation, usually it gets worse in the evenings, though it may not always be so. Dementia is slowly progressive. Over months, somebody is becoming more and more forgetful. So it's a memory impairment in dementia. Whereas in delirium, both attention, consciousness, it's impaired. They may have hallucinations. Like I said, suddenly they'll talk to someone and they'll tell you they can see someone and they're replying to someone's questions. But you don't see hallucinations so often in dementia. And in delirium, there's a disturbance of the sleep cycle, getting up at night, disturbing everybody, and then suddenly sleeping in the day because you're more tired. Sleep cycle may not be affected in dementia. And in delirium, we can sometimes pick up an underlying cause, and that can be reversible. But in dementia, it's progressive and it's irreversible as well, largely irreversible. What are the causes of delirium? There are two easy mnemonics to remember it by. One is pinch me. P stands for pain. Pain could be hidden pain. Okay, they're not able to vocalize that pain. Remember, we're dealing with very sick patients or the elderly patients. They can't easily localize their pain, but there's some pain somewhere. And that's what's causing this delirium and this totally confused picture. It could be an infection. Elderly male, UTI, and delirium, very common scenario. Okay, and especially in those who are catheterized, they can pick up a catheter-associated infection. Or if they are in hospital, they can pick up anything from the hospital environment. It could be a pneumonia, and that causes delirium. Again, here, infection in the terminally ill and in the elderly, you don't often see a fever. You may have fever, you may have a spike in the temperature, you may also pick up a leukocytosis in the blood test, things like that, but you may not have the classical features of an infection. And sometimes delirium is the only thing that will tip you off to the fact maybe this person has got a UTI or a chest infection or something that will alert you to the possibility of an infection. Changes in nutrition. Again, not eating well, person in hospital, less food, not drinking water, that could cause delirium. Constipation. Constipation is a very common problem on our wards. Again, it could be because it could be drug induced, or it could be because they're not drinking enough water, hydration, and then medication, starting with opioids, haloperidol. So many of our medications can cause delirium. And E for Environment. Environment is the sudden change in environment. Okay. Being in hospital for a few days in a general ward, that itself can cause people to have the psychotic sort of picture. We are also used to a hospital environment, it seems normal to us, all these ECG machines and these things that are going beep and the lines and all that. But to somebody, we forget that for somebody who's coming in from outside, these are all very strange things. These are all very upsetting things. And even if they don't show it outside, it's something which sort of, makes them unstable inside, sort of destabilizes them, and they don't sleep well at night. So it's very important that, wherever it's possible, we try to get them out back home, especially in the elderly. In an easy way, if not pinch me, which has 7 letters, you can think of the 5 P's. It's the same thing: pee, poo, pain, pills, and pus. So, urine or urine infection. Again, if he's dehydrated, he won't be passing enough urine. Poo, constipation can cause delirium. Pain, like I said, untreated pain. The delirium may be a sign of there is pain somewhere. He can't localize it, he can't tell you, he can't vocalize it, but try to see if maybe there's some clue that will give you why he's so delirious. Pills, medication. Any of his medications have delirium as a side effect? And plus, that there is infection brewing somewhere, which is what is causing the delirium. So we have different charts by which we quantitatively sort of assess this delirium, and then we can sort of map out a score, and this helps us to objectively assess the delirium, and then we can see if it's getting better or getting worse. We often use this thing called the 480 assessment. But for nurses, what's used is the nursing delirium assessment tool. There are many tools which are available on the net, and every institute might be having a different protocol. But have a look at these. These are all the widely used tools, and as you can see, there's a scoring system, and somebody who's seeing him every day can pick up these small changes and bring it to the multidisciplinary meeting that this change in behavior was noticed yesterday. What is happening to this person? And again, because of the score, it helps us to objectify the delirium. It's so much and it's a little less today, or it's getting worse. What should we do about it? So, what to do when you see someone who's getting delirious? Assess vital signs, including the temperature, check their intake and output, also the stool chart. Have they been opening their bowels regularly? Look for non-verbal signs of pain. I'm sure as nursing faculty, you all know this very well, that someone's pain is not just what they're able to tell us or what they're able to show us, but we can see it in terms of facial expression, we can see it in terms of body language, and we can see it through even if it's incomprehensible sounds, moans, we observe for those signs. Those are all the non-actual verbal sounds, signs of pain. Facial expressions, body posture, and any moaning, groaning sounds. Another very important thing is to check the spectacles and the hearing aid. Very often, when somebody is bringing an elderly person in for hospitalization at home, they forget the spectacles, or worse still, even the hearing aid. Or maybe it stopped working. Maybe the battery has run out. And it's like so scary for them. And they can't even say, they can't tell it was, I can't hear. They just think the world has suddenly gone black, gone silent. I've seen cases of hearing aid causing delirium on the ward. The battery had run out and nobody had noticed. And this person was so little bit into dementia and also getting more delirious and confused on top of that, and couldn't sort of express it to anyone. And finally, they picked up that it was the battery that wasn't working well. So somebody getting confused, look at all the basic things. What are the vital signs? What's his temperature? Is the intake output good? Did he eat well yesterday? Did he drink enough water? Is he groaning? Is he uncomfortable in any way in addition to being confused? Are the spectacles okay? Is the hearing aid? Even ill-fitting dentures. Even if something's gone wrong and it's poking them somewhere in the wrong place in the mouth, that can confuse them. And if there's a team protocol, there's a protocol which you follow to assess delirium, any delirium chart, assess it and document it on that protocol. Non-pharmacological measures, monitor their hydration, make sure that they're getting adequate nutrition. And then we can do something called reorientation. What is reorientation? Especially if they've been in a general ward. Many steps we do in reorientation. First is in the ward, open the windows a little bit, let natural light come in. Have an alarm, have a little clock, a timepiece by the bed. Okay. Have some family photographs, something to bring them in. We all forget, even if we've gone on a holiday sometime, suddenly we'll forget what day it is. And we'll be thinking, is today Wednesday or is today Thursday? What's happening? And then we'll take a couple of seconds to recall that. And you can imagine for someone who's elderly and who's sick and who's just been lying in bed looking at the ceiling for a few days, they lose track of time. They don't know what it is. They don't know which year, which month also sometimes. So have a calendar, have a clock there, bring in some family pictures to remind them of who's there. On ambulation, gentle physiotherapy as much as they can tolerate. And even if it's somebody who can't walk at all, they can go in a wheelchair. They should go out of the ward, preferably be wheeled outside. If there's a courtyard or like some garden place which you have, at least to sit outside, see some natural light, see what's happening outside, look at the beautiful scene and come back. And then, of course, measures to promote sleep. We'll look at each of these in detail again. But then again, it's important to keep an eye on the sleep cycle and make sure that they are sleeping enough. Pharmacological measures, the drugs that we use commonly, especially when they are very agitated, physically agitated, jumping out of bed, what we use is haloperidol. Other medications which we can use is benzodiazepine, we can use lorazepam. And lorazepam, we can give it sublingually also. Just keep it under the tongue and it dissolves and it goes into am. Midazolam also is a benzodiazepine and we can give it subcut or we can even give it IV depending on what the need is. We can also use antipsychotics like olanzapine or risperidone. Somebody can tolerate tablets, and if it's sort of prolonged this delirium, sometimes you need to give them the olanzapine or something like that to reduce the aggressiveness, the agitation, and help them to calm down. And in one of the side effects of olanzapine, especially in the initial stages, as you know, is that they also get sleepy. They tend to sleep a lot. So in a way, that side effect is useful because when you start olanzapine, they start calming down, and the sleepiness actually wears off over time. But at least initially, it helps them to fall asleep and catch up on that sleep cycle. So, so like we said, what did we mean by promoting the reorientation? So we put them in a quiet and peaceful environment. Wherever possible, at least give them the quietest bed, maybe something next to a window. If there's some noise, distraction, sometimes we can't help it. Somebody else in the ward might be causing a lot of noise or distraction. At least try to provide screens. Sit down with this patient, reassure them, try to calm them down. Keep familiar objects, especially favorite pictures, photographs. That's a lot of emotional connect for people. It helps them feel very connected and grounded. And then approach calmly whenever someone is agitated. Identify yourself. Remember, because of agitation, he can't help it. He's forgotten who you are. Possibly things have been brought to the strange place where strange people are trying to control me. So you identify, I'm the nurse, I'm the doctor. We've come to see you today. How are you today? Are you feeling better? Avoid arguments and confrontation. Sometimes the patient just seems like an aggressive patient. Okay, before we sort of pick it out that it's delirium caused by a UTI which is brewing, they'll just be shouting, making some noise, come near you, putting something away and all that. And what is confrontation? Confrontation is like very important. When somebody comes and says something, you don't immediately say the opposite and say, no, this is not that. Comes and says, no, no, I'm getting out of bed, running. I have to go and meet someone. Don't say, no, 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 go back to your bed. Don't cause noise. We have to give you breakfast now. To go to that person, to you have to cause it. You have to catch a bus, is it? Oh, you have important work. You didn't tell me what this important work was. Do you want to tell me what work it is? Come, just sit down. Come slowly, sit down. Tell me what it is. Let's see what it is. Let's see if we can help you go. And then slowly call the family, involve the family. They know the patient best. Okay, and we talk to them nicely and we show that we're all on the same side. We are working together to deal with this delirium. It's not like this is our problem or this is their problem. Okay, we're all in this together. So, patient feels more comforted when family is there. So come help us deal with this thing which is causing someone to behave in this way. And for orientation, I already mentioned you can have a calendar clock nearby. Early mobilization is so useful. help them to be on their feet, take a few steps, gentle physiotherapy as much as they're able to tolerate. And even where somebody can't walk, at least in a wheelchair, and maybe we can use our volunteer service for this, our community volunteers. Take them in a wheelchair, take them outside a little bit, show them the garden area, show them some plants, bring them back in. Because when you think about it, lying in bed, day after day in room, it's almost like solitary confinement. They lose track of everything else that's happening outside. And it can be so distressing for them. And all the while, keep working, transfer them to familiar surroundings as fast as possible, especially if they want to go home, quickly work on their checklist. What do they need to be sorted out? Let's get them better and let's get them home back to their place of safety and comfort. Measures to improve sleep. Okay. Again, in a general word, it's very difficult. But then again, if we think about it, we will be in some way, directly or indirectly, to be able to try some of these measures. Internal lighting should reflect the time of the day. So that means that after 4 o'clock, 5 o'clock, we shouldn't be using bright fluorescent light. Okay, we should start turning down to warm colors, especially if we have the warm yellow lighting. We should slowly switch to yellow lighting and then dim it down and then switch it off at a regular schedule. Okay, lights come on slowly at this time in the morning. Again, not bright lights first thing in the morning. Slowly we wake them up. And then following the natural rhythm, by evening, you should start turning off the lights and switch it off completely at bedtime. So down when you're monitoring light, so that also what comes with it is to monitor screen time, because you can't have TVs and computers and mobile phones, especially flashing light and doing things. All these kind of electronic activity and things should be switched off minimum 1 hour before bedtime, if possible earlier than that also, if you can get the consent of everybody. Switch off these things, encourage them to read, listen to music, activities like that, and slowly settle to sleep. Avoid stimulants late in the day. Now, this gets a lot of people excited and talking usually, because some people will say, I drink coffee to wake up and I drink tea when I want to sleep. And then some people will insist, no, tea will wake me up and I have to drink coffee at night to sleep. And actually, the scientific evidence doesn't tell us anything either way. Okay? It just works for different people differently. Find out for that person. And if they say coffee stimulates me, then please, for heaven's sake, don't drink coffee late in the day. Try it, if possible, to finish, keep all your coffee to the morning. Depending on how bad the insomnia is, don't drink coffee after lunch or evening or whatever it is. Work out the rhythm which best suits you as that person. Okay. And again, at night, try to get the restful sleep. And like I said, even on the general ward, be conscious of it. Let's try to do what we can as much as possible to keep it without distractions, keep phone calls outside the ward, maintain that quiet and peaceful environment as much as we can. Then there is another thing called terminal delirium, which we see in patients who are dying. Now, this is a syndrome which, as a person slips into the dying phase, we see this thing called terminal delirium. As a person slowly dies, what happens? Their consciousness comes down, they become less responsive, the breathing becomes irregular, they don't eat as much, their swallow is less, they can't drink much. But this delirium, this agitation, this confusion, you can sort of see it in the last days or hours of life. And it could be sometimes just sort of this low muttering, saying incomprehensible things. It's like as if they're trying to talk, but they can't talk. What are they trying to say? Usually it just stays at that level. For some people, this terminal delirium also can be a more aggressive picture. They can be so confused that they're rolling out of bed, falling out of bed, or even trying to get out of bed. Okay. And like I said, it's different degrees of agitation or restlessness. It's not possible to arouse them from this. Usually they are unarousable for this. And if you look at it, depending on different people's spiritual beliefs, there are a lot of spiritual beliefs around this. So that's why I'm mentioning a few that I know. I hope I'm not wrong. Like the Buddhists believe this is like a passage of the soul. And some I think the Celtic Christians also have something about transitioning from one world to the other. And why I'm mentioning this is different people have different beliefs about how they want this to be addressed. Like Buddhists don't like too much of sedation to be given because they feel that this person is, like making up for whatever mistakes or whatever, and they don't want them to be fully knocked out like that completely. Unless, of course, you're jumping out of bed or something, in which case you have to do something. But otherwise, it's important to understand the spiritual background, their beliefs, and to liaise closely with the family to see how we can manage terminal delirium. There's a lot of medication available for it. We can give them midazolam and we can go up on midazolam to quite a good dose. Okay, so we can get them calmed down and less agitated and settled, depending on what sort of a balance we want to achieve. It's important to educate the family about this. Okay, because for the family, it's very distressing to watch. Okay, terminal delirium, at least they've sort of accepted somewhat that this person is going to die. But then again, they're worried. Why are they saying these things? What's happening? Are they, is something happening inside? Are they hurt? Don't they shouldn't, would you, no, no. Sometimes they may say, just give them something, help them to sleep better, let them be calm. We want that way. And again, like I said, if it's not exactly the end of life stage, but before that, if it's somebody who's wetting himself, being incontinent, shouting, then it's very, very, very distressing for the family. It's important that delirium is something which is addressed quickly as an emergency. Why is this happening? Is there a reversible cause? Think of the pinch me mnemonic. Is there pain? Is there infection? Is there nutrition mistake? What is happening? Try to fix that or radically fix the symptom of the delirium as well as the underlying cause. So that brings us to the end of the little bit on delirium. We've got a little time for questions now. Anybody has any doubts about what we've been discussing so far? You can unmute yourself, feel free to ask your questions. Or you can also tap it in the chat box. Is there anything in the chat box? Anybody like to share any thoughts on delirium? Any patient whom you've seen where you've had to deal with delirium or where you tried something unusual perhaps other than what has been mentioned here? Or just the experience of dealing someone, a patient or families where delirium was an issue? Anybody recall any case, anything you'd like to bring it forward and share it with everybody? Okay. So in that case, we'll just move on to respiratory symptoms. Okay. So there is one question. Yes. Parkinson can cause delirium. Yes. So it's a question. So Mudita Yatamash. So, as such, Parkinson's is not, delirium is not like a feature of Parkinson's. Parkinson's, as you know, there are lots of motor symptoms. Okay, there's difficulty in initiating actions. They have rigidity of the muscles, and then they have tremor. They have involuntary movements called tremor. But in any disease, in the very advanced stage or in the end stage, they can become delirious. They can become confused. And then in Parkinson's, there are certain medications that we won't use, like haloperidol. So we usually go for other medications to help with the agitation. Any other questions? He said thank you. Okay, thank you. So what I will do is I'll go on to respiratory symptoms. And even as we go along, you have any thoughts, feel free to share it with us. So coming to respiratory symptoms in the palliative care setting, I can't get the slide to move. There. So initially, if you look at it when palliative care started, just a little bit about the history of palliative care. So as we all know, palliative care started largely as an offshoot of cancer care. It was about supporting patients with cancers, patients and their families with cancers, because as we know, cancer is a disease which affects not only the patient but also affects the whole family. Okay, so palliative care started as an offshoot of oncology, but with the passage of time, it's come to include more and more diseases. And nowadays, palliative care is also like for end-stage respiratory disease, heart failure, kidney failure. In neurology, it's for dementia patients, Parkinson's patients, motor neuron disease like amyotrophic lateral sclerosis, and others. And nowadays, they feel that it's almost like 50-50. Half the patients are cancer, half the patients are non-cancer. And in some setups, the non-cancer patients are more than the cancer patients also. And if you look at the non-cancer group of patients who need palliative care, a large group of them are from lung disease. Okay, and what are the lung diseases that could cause people need palliative care? Often it's COPD, could also be interstitial lung disease or any environmentally caused lung disease. And in India, we have a huge burden of tuberculosis and multi-drug resistant tuberculosis. And as you know, that can sometimes especially with multi-drug resistant tuberculosis and anything, depends on the extent of pulmonary damage can be huge. Okay. India has 18% of the world's population and 32% of the total global health loss from chronic respiratory disease. So not only is our burden of respiratory disease quite high, but the loss of health due to the respiratory disease is also quite high. So it's something which is very, very important for India. And as we go through this topic, you will see that in respiratory disease, the non-pharmacological management plays a huge role. It's a very, very important aspect of care. And it's something where we should all keep training ourselves so that we can provide as good care as possible for our patients. So, looking at the management of pain in India, okay, in the suboptimal care overall. Okay. So death was expected, meaning like did they the surprise question, did they anticipate, did they prepare the patient for death? So when COPD is not addressed so well, but in cancer patients, we know to address this. At least we started addressing the question of dying and providing a good death. Also, patients with COPD had less access to specialized home care services, palliative services. We are extending our palliative care net a lot to cancer patients. I'm speaking in general. Okay. Very often it's found that in general, COPD and respiratory patients are somehow forgotten. They are like separate. And they also have a lot of pain, they have a lot of anxiety, they have a lot of depression, just like cancer patients. They've also lived with their disease for many years. And actually, end of life discussions and things like that, people don't do it so often with COPD patients. Somehow people have it on the checklist for cancer because people often are like, is the cancer cured? Is it going to come back? But that's not something that's discussed so often in COPD. So there's more of ambiguity there. There's more of a dilemma there. There's more of this emotional distress there. COPD patients are more likely to die in hospital because when someone is breathless, if you think about it, it's more scary, sort of. So it's sort of triggers hospital admission. Okay. When someone who's had respiratory disease for years, if they may be on home oxygen, they know that now their condition is not at a point where it can be reversed. Still, with COPD patients, like I said, that end of life discussion has not been had. There's more hospitalization, and it's very important that we stretch, that we extend palliative care to bring in lung disease and COPD also into the palliative care net. So, along with the respiratory disease, other than chronic obstructive pulmonary disease, it could also be ILD, interstitial lung disease, pulmonary hypertension, and things like that. So, the question is, why are we denying our patients with chronic respiratory disease the access to palliative care? And it's just this common myth, palliative care and cancer. It's not just for cancer, just for other diseases. And we should not forget respiratory diseases because in our country it's a huge bulk of disease and we have to pay attention to these patients also. And again, like I said, respiratory disease, one of the huge factors which helps with the respiratory disease is non-pharmacological management, how well we can rehabilitate them and look after them. So what are the respiratory issues in palliative care? So first of all, the thing is that we need to bring palliative care to address respiratory disease symptoms. Like I said, the other thing is the respiratory patients may also have other non-respiratory symptoms going on in palliative care, and we have to look at those issues also. Okay. And then other patients dying from other disease also, respiratory symptoms is very common in that because breathlessness is very common to people dying from any cause. Okay. And in all end of life discussions, they'll be coming into respiratory medicine because we're talking about what happens when they stop breathing. Okay. Do you want to ventilate them? Do you not want to ventilate them? So it's very important to understand, respiratory irregularity, things which can occur, and why management of respiratory symptoms is very important to be aware of. So this is a very, very important evidence-based, a piece of paper that was published. Okay, and when it came out, this came out in 2014, and this was an eye opener. They did a randomized control trial of 105 patients with advanced respiratory disease. Okay, that could have been maybe COPD, ILD, cancer, but basically the thing was they were suffering from refractory breathlessness. Breathlessness that was just chronic and progressive, because basically they had chronic progressive diseases which were not reversible. So what they did was they divided these patients into two groups, and to one set of patients they gave them the usual care. To the other set, they gave something called integrated breathlessness support service. So, what this integrated breathlessness support service is chest physio, okay, closed focus respiratory, like breathing techniques, training like that, and palliative care, emotional support, education, communication. And they found they had a higher, not just patients coping and symptom control was so much better, but at 6 months, the survival itself was better. And this brought about such a big change because here it is palliative care and is shown as actually improving survival. Okay, we think palliative care is about letting go and making people be on, just having a very peaceful death, but it's not. Where you give active palliative care, you can actually improve prognosis. You can actually help them live more comfortably for longer. What are the common respiratory symptoms that we see in palliative care? Most common, of course, is breathlessness. Yeah. Along with the breathlessness, there can be an associated cough. This cough may be a dry cough or it may be a productive cough, as we know. Then in end of life, we see noisy breathing or terminal secretions, the death rattle, that bubbly sound in the chest. Then in our patients with secondary lung cancers in the lung, either primary lung cancer or secondary metastases, along with the cough, they may have hemoptysis. Coughing out, blood, flecks of blood, maybe more blood, and sometimes it can be a huge life-threatening hemoptysis also. Very often our patients complain of chest tightness and respiratory fatigue. Okay. They've been breathless for so long that they are now going into respiratory fatigue. So the respiratory symptoms, what causes the respiratory symptoms? Could be either directly because of the disease, be because of treatment, or it could be due to other causes. Now, what are the disease-related symptoms? One is directly because of the tumor, the growth and the spread, or directly because of fibrosis in the lung. The lung tissue has lost its elasticity. It could be because of airway obstruction, okay, due to airway constriction, or it could be that there's some tumor which has grown and obstructed the airway. They could have an associated pleural effusion. In many tumors, as you know, there's fluid sitting in the pleural cavity, and that doesn't allow for lung expansion. Or they could have an infection. Infection could spread rapidly in the terminally ill, and you'll often see one whole lung is quickly becoming one opaque zone. Treatment related, a lot of chemotherapeutic agents have pulmonary toxicity, lung toxicity, and radiation fibrosis also. The radiotherapy can also cause fibrosis in the lung. And then general causes, anxiety. We're all familiar with that anxiety in our very ill patients. Anxiety, as we know, with breathlessness, it sets up a vicious cycle. And this is something we see so often and often struggle to break. When someone is more anxious, the respiratory rate goes up. And as the respiratory rate goes up, they become even more anxious. So it sort of feeds into this vicious cycle, and we need to stop it and break. Very often, we have to remember that when they are going into this hyperventilation, what we need to do is to calm them down. And that will reduce the anxiety, reduce the respiratory rate, and hopefully slowly allow it to come back to normal. Anemia, where there's insufficient oxygenation, they're going to be breathless. Then fatigue, just the fatigue. Okay, as you know, having a cancer in your body causes cachexia, it causes fatigue. They're not eating properly, they're not drinking properly. Breathlessness is seen in people with lung cancer, primary lung cancer, or a metastatic lung cancer. We also saw that it can be seen in patients with chronic lung diseases. Could be COPD, ILD, any of them. Heart failure. Okay. Up to a certain point, you can keep titrating medications and you can try to improve heart function and you can try to see if you can improve the output ejection fraction. But after a certain point, the ejection fraction is going to keep failing. And slowly, as the heart failure worsens in the end stage, what will be the most predominant symptom will be breathlessness. Many neurological diseases, again, end stage, it could be breathlessness, okay, starting with motor neuron diseases and others. So, what is breathlessness? We use the word dyspnea. Dyspnea means the patient is uncomfortably aware of his own breathing. Okay, and along with this breathlessness, this difficulty in breathing, there may be an associated cough, which can be dry or productive, may or may not be a fever. Sometimes he could be wheezy. He could have hemoptysis. He could be coughing and bringing up blood. Or he could have a stridor. What's a stridor? A stridor is that 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 noise, that wheezy noise you hear as a thing goes, as the air goes in and out, and usually that's indicative of some obstruction to the airway, okay, or the blood vessel. We see this often in a lymphoma or in an SVC obstruction when there is something compressing here, the great vessels of the neck or on the trachea. Usually, when you hear a stridor, it's a sign of an emergency. You have to do something fast. And then he could have pain if there's a pleural effusion or maybe rib extension. If there's a tumor extension into the ribs, he'll also complain of an associated chest pain. So, what are the goals? First is relieve the distress, make him feel better. As I said, there's often accompanying anxiety. Monitor sedation. Okay, now it's important to achieve a balance here. We can't withhold sedation because they need to be less agitated and we need to bring down the anxiety. But at the same time, we just make sure that it's not going too high to reduce the depression or anything like that. Now, important supportive measures to provide laxatives. Okay, because straining again at stool could make the breathlessness worse. And last but not least, most important thing, reassure the patient, stay with the family, explain to them what's happening, and support them as much as possible. Okay, now to relieve the distress and to improve comfort, we can do it through pharmacological and non-pharmacological means. So let's see how we can achieve these goals. Need to assess the patient. You can ask them to rate the breathlessness. Okay, just like how we ask them to rate pain, we can ask them to rate the breathlessness. And again, this is a good objective measure, which gives us an idea. Is the breathlessness getting worse? Better. See, breathlessness, we said, is a subjective thing. Patient is uncomfortably aware of his own breathing. So it gives us an idea whether he's becoming a little more comfortable and settled or no. Is the panic rising? Is the discomfort rising? Observe the patient to see if the respiratory accessory muscles are being used, count the respiratory rate, see if there's costal indrawing. Also sort of assess his psychological state. Is he anxious? Is he agitated? And if required, okay, only in conditions where it's been indicated, measure the oxygen saturation and let the medical team know. Is this a state condition? Is it where is he in the illness trajectory? Are we trying to treat it with oxygen? Are we trying to make it better? Or is it in the end stage where we're only aiming at comfort care, where we're aiming to relieve the discomfort of breathlessness? Okay. So what we should remember, always remember, is breathlessness is subjective. Dyspnea is subjective. Okay, hypoxia is an objective measure. Oxygen saturation is so much. But dyspnea is a subjective measure. And when there is dyspnea, we should know, are we treating this patient proactively? Do we need to measure hypoxia? Do we need to correct the oxygen saturation? Or has it been decided that this patient is for comfort care only? And in that case, we should manage the comfort and relieve the discomfort of breathlessness. In that case, it is important to treat the patient's distress, not the SpO2, remember. So first thing to do is cool air, switch on the fan, open the windows, handheld fan. Now, the importance of a handheld fan can't be overemphasized. This has been shown again and again in evidence based studies how quickly it relieves the breathlessness and how much it can help patients. Okay, because it's believed that when you have a handheld fan, when you have this movement of cold air right in front of the face, it actually stimulates, maybe it stimulates the nerve endings of the trigeminal nerve. Maybe there's some feedback mechanism that has been postulated, but definitely we know that the benefit is there. Most people, the breathlessness seems to improve with the handheld fan. Calm and quiet environment, trying to calm it down, talk to the patient, reassure them, make sure there's adequate ventilation inside the room. There are some relaxation techniques which you can try. We'll come to the relaxation techniques. And like I said, emotionally reassure the patient. What are the best postures for them? Okay. If they're sitting, then ask them to lean forward. They can brace themselves forward. If they're lying and if they can lean down, lean forward, that's one of the best postures. The other thing is, if they're lying in bed, maybe you could be on the side and see if you're able to raise the head and does that release the discomfort. Okay. They could also, if they're standing, lean forward on a chair. Some people find that forward leaning little more comfortable to bear. Oxygen does not help in all cases of dyspnea. Okay. If the patient is comfortable without oxygen, it may not be necessary to give him oxygen. Like I said, it's important to know the underlying diagnosis and where the patient is on the illness trajectory and whether this is a patient who's going to benefit from oxygen or, and if it's not somebody who's going to benefit from oxygen, there's no point at all anybody becoming breathless towards the end, run, bring the oxygen, not necessary. Okay. As we know, oxygen can be delivered in many ways through nasal cannulae. You can have an ordinary face mask, you can have a venturi mask, you can have the airflow control masks. And when you give or when you administer these through these cannulae or masks, or when you're giving oxygen, remember you should also like monitor for hydration, look for dryness of the mouth, look for irritation of the skin. Okay, and of course, background fire safety precautions and things. Of the medications, what's most useful for management of breathlessness, evidence-based, is low-dose morphine. Okay, low-dose morphine, we usually start, if we're giving morphine only for breathlessness, with sustained release, we'll give it as 5 milligrams twice a day. And we go up to maximum usually of 30 milligrams a day of morphine. And for breathlessness, usually morphine, that is the levels at which we help for look at for breathlessness. It reduces the sensation of discomfort. It reduces this uh, all the anxiety, that feeling around the breathlessness, and it eases them and makes them feel better. You may have to give medications alongside, depending on what the cause is. Not in every COPD, you can try a bronchodilator. Like I said, it depends on where the patient is in the disease trajectory. And if this person is still having some measures like that, then you try that. You can try corticosteroids. Sometimes, like I said, even in end stage, it may be the breathlessness may be due to superior vena cava obstruction. There could be what we call tumor obstruction or some other inflammation. And sometimes the decision may be taken to give him a trial of dexamethasone. Okay. But the important thing are all the non-pharmacological measures. Coming back to that as a sort of long-term service where we know in patients where breathlessness is going to be an issue. So it's important to sit down and have both a counseling conversation and educational sort of conversation and trying to work out what helps this particular patient. Okay, so it's to talk to them. How does this breathlessness affect me? For a lot of people, when that breathlessness starts, it like sets off a cycle of panic and anxiety. I'm getting breathless, quick, get this. I must get my oxygen. I must get my inhaler, something like that. It's important to make them aware of that pattern of breathing. Okay, it's important to sort of be able to teach them. Take your handheld fan. And if there are relaxation techniques, sort of can teach them how to do those relaxation techniques. I'll come to that better. Okay. And as a long-term measure, we think of these things called the 5 Ps. You might have heard of it before. I'm sure you're familiar with it. 5 Ps are prioritizing. This is like activity planning. So we tell the patient when they wake up in the morning itself to decide what are all the things they need to be doing that day. Okay, and then you prioritize it. Okay, you see which are the most important things that you need to get done. Okay, and the less important things, okay, maybe you can keep it for a little later. Don't try to do everything in one day. So it could be that you need to get, it could be for a patient that they just have to get up, do their morning personal care, and maybe come up to the kitchen and help a little bit in the kitchen. Okay, so you plan it. At what time do you wake up? What time do you need to come out and start helping in the kitchen? Don't walk up and down and tire yourself out. Okay. And if there are 2 or 3 things that you need to do, pacing is doing that. First, do this much, give yourself some rest, then do something else. You sort of have to plan and you have to do it at the speed, at the pace in which you can maintain your comfort without getting tipped into becoming very breathless. Positioning is actually planning yourself. How are you going to be in your house, your room? Okay, so here I'll be in my room. If I come out of my room, I'll go into my kitchen. I'll finish this. Then I'll come to this table and chair. I'll sit here, going to rest for 15 minutes. Next, I'll do that, whatever. Go here for lunch, go up to this table, sit here for lunch. So plan actually how you're going to do your work, position yourself. And permissions is giving people permissions to help you. If a neighbor comes and says, I can help you with vegetable shopping, things like that, reach out, accept that help. You may have to involve your family as well. Okay. This is the 5 finger breathing technique. So, what is this helpful is? This is like a very important, it's a sort of mindfulness measure. And there are many kinds of breathing techniques. And as you know, in yoga itself, there's a lot of breathing which we teach them to calm them down. This particular hand is the breathing hand, this 5 finger technique was developed in Oxford and it's used in a lot of places. So basically, what you tell the patient is to open your hand. It's called the open palm technique. You can even try it now as we go through it. Tell them to keep their palm open, close their eyes, slowly start from the base here. Run their finger up the thumb. As they go up, they slowly breathe in. And as they come out, they slowly breathe out. Again, breathe in and breathe out. Breathe in, breathe out. Breathe in, breathe out. Breathe in, breathe out again. And you just teach them to do this. And as we all know, this sort of guided breathing, it has a very huge effect, both emotionally and in setting the breathing, especially this vicious cycle, becoming anxious, more breathless, anxious, more breathless. It helps to stop that cycle and it helps to slow down the breathing and set it back. Now, like I said, the variations of this 5 finger breathing technique, there's many. There are many yoga techniques also, which our people may be more familiar with. Whatever works for everybody, they can try what helps them. And that's something that is very useful. So this is something that we could educate our patients. When you feel that breathlessness is coming down, when you feel it's coming on, open out the windows, switch on the fan, keep your handheld fan close to your face. And as it's settling down, not settling down, just keep the fan next to you. Try the 5 finger technique, breathe in, breathe out, do that. And of course, if it's very anxious, they could have SOS medications, which are then given for anxiety. It could be like lorazepam or something, but that's more advanced. And as it's come out again and again in evidence base, just educating them about breathing management techniques, things like that, goes a long way in making people feel better. So often accompanying breathlessness, we saw is the symptom of cough. And what do you mean by refractory cough? Sometimes they say it's more than 8 weeks. Some people have a measure like that, it goes on. But basically, it's persistent cough that does not respond to any standard treatment of the underlying cause. Now we see this refractory coughs in people with lung cancer. There must be something triggering the bronchi. Okay, maybe this bronchial wall invasion, or the disease has spread so widely that it's just triggering off the cough reflex. It could be there in chronic obstructive pulmonary disease. Usually they're chronic smokers and they have chronic cough as well. Could also happen in interstitial lung diseases. Could happen in heart failure, where they have chronic long-standing pulmonary edema. Could occur due to airway irritation or tumor compression. You could see chronic cough post-radiation, and it could also be due to infections or secretions sitting in the bronchial tract. So the impact of this cough is distress. The distress, there's a lot of physical distress and there's emotional distress. Just coughing and coughing causes a sort of respiratory fatigue. The respiratory muscle feels weak. Okay, and accompanying this coughing, remember, they can have urinary incontinence and they can also have rib pain. Another reason why the cough is so distressing is that they can't sleep well at night. Sleep is so important in this situation, and many patients are woken up from the sleep because of coughing. And once they start coughing, you will hear it often from your patients, isn't it? It just spoiled my sleep, and then whole night I was just coughing, coughing, and then I couldn't go back to sleep. And as we know, it can cause a great deal of fatigue, and it can also become breathless. That dyspnea, the cough is so bad, it sets off a dyspnea. This dyspnea and cough are correlated. And as a result of this, the quality of life is much reduced. They're so scared to talk to people only when they come. Sometimes they're scared to eat or to swallow because they're worried it'll set off a coughing. And when people are there, they're scared if I talk or if I speak and if I start coughing, then it looks so embarrassing in front of everybody else. So again, what we need to do for this cough is to assess the severities, assess the duration, check the sputum, check if there's hemoptysis, how bad is the dyspnea which accompanies the cough, and then again try to gauge how is this cough affecting his sleep, how is it affecting his day-to-day activities. Again, in palliative care, what we do is we focus on the symptom burden and we try to see how we can rehabilitate and help him with these symptoms rather than getting into extensive investigations, because it's possible that the investigations have all already been done and we know the underlying disease and we know that the underlying disease can't be reversed. So no point in just repeating things over and over again, but focus on the cough, take a very, very good history, talk to them, find out how this cough is affecting them and how can you suggest, what can you suggest to make that particular thing better for them. So non-pharmacological things that sometimes help in dealing with cough is to give them humidified air. Okay, and also make sure that the patient is adequately hydrated, because when they're coughing and coughing, there's invisible loss of water. Positioning may help. Sometimes the cough is triggered by something called the postnasal drip from one of the sinuses back into the back of the throat. Or even because of others, maybe even secretions in the tract, things like that could be stimulating the coughing. So it's useful to try to position the patient and see if some particular position makes it, eases it, or helps it. And just as with breathing, for cough also there is relaxation techniques. You try to see, I try to tell them, like when the cough is about to start, when you feel ticklish, we sort of give them breathing techniques to breathe that ticklishness away, that cough tickle. And you can treat them deep breathing techniques to get past that. Sometimes they also rehabilitate them, try to give them a sip of water or something at the time to stop the coughing. And then, of course, you can try, cough lozenges, things like that. Keep something in your mouth. Does that help? Pharmacological measures, there are a few. We can try codeine. It's an antitussive. Morphine in a low dose also may help with cough. When there's a chronic cough, we can try neuromodulators like gabapentin or pregabalin. If there's an associated inflammation, perhaps steroids may help. Try to see, suppose in the underlying cause, even if it's a huge disease that you're dealing with, maybe there is some reversible component to that. Can that be in some way adjusted so that the cough is better? Rule out, like we said, whether there's an accompanying asthma. Is there some hypersensitivity? Is there a postnasal drip? Is there gastroesophageal reflux? Because acidity can stimulate cough. He may be on medications like ACE inhibitors, which have cough as a side effect. Okay, and anything else? What else is there in addition to the disease? Now, one of the very distressing things of cough that we can have is hemoptysis. Hemoptysis is when a patient starts coughing out blood. Very often, it's only small amounts of blood, or specks of blood, or streaks of blood, which is self-limiting. Like he coughs up a little bit of blood, and then it stops. Okay, what's important that the medical team is informed about this, so they can see, is he on some medication that should be stopped? What should happen? Okay, but usually, if it's small amounts of hemoptysis, and if the patient is sort of okay, quickly self-limiting, we watch. The important thing here is reassurance. Okay, positioning the patient, keep them upright. Do not nebulize. Don't try to do any unnecessary measures. Very important to calmly reassure them. Let them know that there is help at hand, you're there with them. And keep dark towels handy. This is for a hemoptysis, which is not settling down with after one or two cough, or it's not just a streak of blood which is going away. Let's say he's coughing up some frank blood, and we know this patient has a lung cancer, he has a huge tumor there. Is this the end stage? Suddenly he brings up one big blob of blood. Okay, what's happening here? Position the patient, okay, reassure them, keep dark towels handy. Why dark towels? As we know, it's to avoid the blood stains. Again, we are all used to seeing the blood, doesn't sort of affect us like that. But to some people, and especially to family members, seeing those red patches on white, it can be the most distressing thing. They'll just break down and they can start crying when they see that blood coming out. So if you have like dark brown or red or any dark color which doesn't, show those contrasting red patches, it's a big help with the patient also and for the family also. You can try some medications in this setting. Okay, there's morphine to alleviate the dyspnea, the sense of breathlessness. It's very important to give midazolam for sedation, because though we are reassuring them, being with them, you have to be there, but also give them something to sedate them, because this huge cough, it can be so agitating for the patient. And then tranexamic acid has been tried to control the bleeding. Okay, it can be tranexamic acid can be started. We know that if there have been early warning signs, we can give them tranexamic tablets, acid tablets orally. And in some very, very specialist palliative care units, sometimes they also give tranexamic acid as a subcut infusion, but that's very rare. Stay with the patient. I think the best thing that you can do for the patient as a nurse is to stand there and provide a calm, quiet environment for the patient and with the family. Avoid unnecessary procedures. Okay. Support the family and again use dark towels as necessary. If they've already been written up for SOS medication, then maybe, and if you've been given the permission, maybe you can give some midazolam to calm them down. If they've already been on tranexamic acid, make sure it's continued. And maybe they may need some low-dose morphine if they're not already on it to reduce the breathing difficulty. And we'll come to the last respiratory system symptom which we are going to discuss for the day, and that is terminal secretions. And we all know that as the patient goes into end of life care, we'll hear this bubbly, this rattling in the chest. We call it the death rattle, but basically it's the secretions in the chest which are not absorbed. Remember, the patient is not swallowing. All the secretions in his mouth, the saliva, which is pooling, everything may just be going down backwards. Okay. The important thing here is to reassure the family that the patient actually doesn't notice this. The patient is not distressed. It's more distressing for the family members actually to hear this noise than it is for the patients themselves. Okay. If the terminal secretions are like slowly brewing, you sort of hear at the initial stages that low bubbling, you can start glycopyrronium. That medication helps And remember, glycopyrronium, what it does is it's an anticholinergic and it prevents secretions. So you should give glycopyrronium is something that should be given in the early stage. As soon as you start hearing the delia, that rattly noise, the medical team should be alerted and it's good to start it early. Because once the secretions are already there, remember glycopyrronium is not going to clear out the secretions. What it does is it stops secretions from coming in. So it's important to start glycopyrronium early. Other thing which helps is just positioning the patient, okay, so that it sort of drains to one side. And the most important thing is to reassure the family. Tell them, look, this noise, this is something which happens often in the end stage. Most likely the patient doesn't feel it, but that rattly noise, we understand how you must, we can try to understand how you must be feeling. It will be probably possibly being more distressing for you than for the patient themselves. So again, what is the role? Important thing. The role for nurses is early communication with the medical team, provide comfort measures, educate and reassure the family, make them understand that this is what is happening, and maintain the atmosphere of dignity, comfort, and calmness. Now, again and again, you would have seen that in the slides, I'm saying reassure, calmness, maintain. Because if you come to it, really, that's one of the most important things of palliative care itself. Coming to the 7 C's of palliative care, what are they? One is communication, communication with the patient and communication with the family, making them understand that this is what is happening. Sometimes preemptively, you should tell them this is what you can expect so that they are prepared. Okay, and it's not a sudden shock when they say something. Coordination among the different teams providing care so that we are working together holistically. We respect boundaries, but we are also coming together, each of us to do our best to for the control of symptoms. See, again and again, we have to remind ourselves we can't cure this disease. We're not going to take away this disease, but let's control the symptoms as best as we can. There should be continuity of care. It should be a continued learning process. Every time we're learning how to do things better, and we should never forget carer support because possibly someone who's suffering as much as the patient is the carer at home. And how we provide good care for the dying. And after dying, how we continue to care for the family, provide good bereavement support for them, and we are there for them. Just a quick note, not to forget this, something so important, caregiver stress. And you see this in high amounts in delirium and in respiratory symptoms. So there's a lot of discordance in what they perceive about the patient's quality of life. They think, about the distress, something is happening to this person. So it's important to address that concern and it's important to address the physical symptom. It's a huge financial stress, and we should always be mindful that we are, very using resources where it's most useful. And even in the patient's personal finances, and it's also in this community when we work within a non-profit organization. It's important that we use our resources wisely so that we're using it people who need it and it's not being wasted. So, and then we may have to educate different carers on different kinds of home care depending on what that patient's needs are. Okay, it could be about NIV or tracheostomy, or it could be other kinds of care, how to manage with breathlessness when it comes on, and things like that. Educate them in advance how to recognize acute emergencies, okay, and backup plans for that. Loss of mobility, how can they cope with it? Loss of stability, how can they provide a physically supporting atmosphere, grab bars, everything like that. Talk to the caregivers also. Talk to them about anxiety, depression, compassion fatigue. If they've been looking after someone for months, years, you don't have to feel guilty if there's some compassion fatigue. We're all humans and we have only a finite amount of everything. And burnout. Okay, understanding, reaching out to them will prevent burnout. Okay, nurses are, as they say, better than doctors. Sometimes they're more calm and it's also that along with the psychologists we also participate in many end of life care and also be involved in bereavement counseling. This is a very important quote by Dame Cicely Saunders. It says the last stages of life should not be seen as a defeat, but rather as life's fulfillment. It is not merely a time of negation, but rather an opportunity for positive achievement. One of the ways we can help our patients most is to learn to believe and to expect this. So it's not to say this is the end of life and this is what it is. What do you need to do? What are your goals? What are the things you want to do in this time that's available? This is precious time. And let's try to help you do as much as you can in this precious time. Thank you. Any doubts? Any questions?
Thank you, Nirupa ma'am, for the wonderful session. Anybody have any questions or comments?
Thank you. You can unmute yourself and speak directly into the mic, or you can type in some any doubts or anything that you have. Or you can even share some experience. What comes to your mind when you hear about this delirium and breathlessness? Is there some patient whom you manage? We all sort of remember some cases that sort of affect us more than other cases. Is there anything that you would like to discuss?
Could you please switch on your video so that we can able to see you? Yeah. Thank you. Any questions? So you are going to teach these things to your students. So please clarify your doubts and share your experience.
Any interesting case which you have seen also where you may have had to take some unusual measures to continue to control the symptoms? Anything you would like to share with all of us? Okay, I'm going to talk more since nobody else is talking. You'll have to listen to me share an experience. When I think of delirium, this patient always comes to me first. So this was an elderly gentleman who had prostate cancer, which had metastasized. So family was educated, family was aware. He was in his early 80s, and they knew, that time has come for father. At least they were prepared. They knew the cancer has spread. But how he was being looked after at home, and the plan was to look after him at home as much as possible. His pain was not so bad. It was managed with a baseline sort of, just usual level of doses. Suddenly, this man became delirious. Okay. And because of the delirium, he had to be hospitalized. He became so aggressive. He started shouting and he was screaming, and he was at home. Only the wife was living with him. The son and the daughter were living close by. But I think one person was out of station and another person was in another place close by, and it was getting late in the night. The wife brought him to hospital. And this man was so aggressive. He had actually worked as a shop owner and quite a good shop with business. So he was used to supervising so many people under him. He was like always in a position of authority. And even in his family, he was like the Periyappa, like he was like the eldest brother. So he had younger brothers, and all those nieces and nephews also will look up to the elder uncle for advice. And in this distress state, in this terminal, in the stage, what he did is he was using such bad names. Nurses couldn't even approach him to give him midazolam or benzodiazepine to calm him down. And he was pulling at his urine catheter, because of the prostate tumor. He'd had retention and things for a long time. He was pulling at it, and then he tugged so badly that the urine bag got disconnected, and it just, sloshed all over the room. And it was difficult even to go in and try to clean up, initially till the sedation went in to get him to behave. And the mother was there, and we tried to calm her down, tell her, we were taking all the measures, and the daughter came in. And I remember the daughter was the one who was so inconsolable. First time we've seen difficult pain things, this delirium in a girl and crying like that, because she could not believe that this was her father. Her father was this respectable man. Anybody looked, she was all the time like, why is he talking like this? Has he become mad? Why is he doing this? And till that medicine went in and he calmed down, and we had to give him we had to escalate the dose actually to finally get him under control. But it took a few, for that to go in a couple of hours, things to come down. By then, this girl was crying so much and she was in so much of anger. Why can't you do it? And we had to tell her we just can't simply go and throw in sedation like that. Also, he's elderly. We have to do it step by step. But finally, okay, there was some peace that was achieved. But when you think of it in a palliative care setting and delirium, for me, this case always comes back to mind. And I'll never forget that girl's distress because of the way the father was behaving. She kept saying, "This is not my father. This is not my father."
Yeah, thank you for sharing this. Similarly, what we have to understand is Madam has covered a lot of things. And whenever a patient is complains with delirium, usually the caregivers will be reporting the patient is having delirium. So it's our duty to identify the underlying cause. So there are many causes, precipitating factors for delirium. So it could be drug-related causes. It could be urinary retention. Could be constipation. It could be unfamiliar faces and environmental changes and electrolyte that changes. These all things are there. So we have to, it's our duty to identify the cause and do the proper assessment. If possible, try to manage the underlying cause. For example, constipations. We can do the PRE. You have to take a proper history and do a PRE and manage. So you can, as nurses, we can do that, right? So you can do the manual removal. You can give an enema, or we can put a suppository. So these are all the manageable causes as from the nurse's side. Then and also you have to educate the caregivers, because when they start irrelevant speech, they might be thinking like mad. So you have to give a proper reassurance. Is not mad. Why this delirium developed? What is what was the cause? These all things you have to educate them and give a reassurance and be with the patient. And when we come to the respiratory symptoms, if the patient is having respiratory problems, usually they will be in anxious. So what is next? So you have to tell the nursing students, if wherever possible, they have to be with the patients and that uh, talk to the patient and talk to the relatives and give a non try to that give a non-pharmacological management first. And if the non-pharmacological management fail, then you have to think about the pharmacological management. So wherever possible, be with the patients, and that way we can able to reduce the anxiety level. So the if the patients become anxious, the respiratory distress will increase. So that also we have to keep it in mind. Always you have to keep the total pain concept in your mind all the time. Okay, thank you. Rest of the points Madam has covered beautifully. So if you don't have any doubts, we can wind up.
Yeah, so ma'am, I really want to sincerely I want to thank you and appreciate ma'am. So literally, ma'am is in Sparsh and she rescheduled her flight to Chennai to take this session. And thank you for your commitment, ma'am. Thank you so much.
Thank you. It's
So
always a wonderful opportunity to be back with Pallium and with Sparsh. So thank you for the opportunity.
Thank you, ma'am. Thank you.
so I think we can wind up for today. Yeah. So thank you, ma'am. Thank you so much. Thank you, Shiva, ma'am, for facilitating today. So you can leave.
Thank you. Thank you, Robin.
Yeah.